Hello, and welcome to the CAP Today webinar for Tuesday, September 17th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host and moderate a question and answer session after our formal presentation. Today's webinar is entitled, "It's Hard to Treat What You Can't See. Perspectives in Molecular Oncology Diagnostics." This very important webinar is made possible today by a special educational grant from Thermo Fisher Scientific. We want to acknowledge Thermo and particularly thank them for this critical support for this program that is of great import today. Our speaker today, and I'll say more about her in due course, is Dr. Yi Ding of the Geisinger Medical Center in Pennsylvania. And before we begin, let me just give you a few housekeeping tips to enhance your enjoyment. We often suggest that you refresh your browser today to keep syncing optimal. We offer live help with real people throughout the webinar today. You'll see in the bottom right-hand corner of your screen, you can call for technical support at 858-345-5916, and that's for either audio or website problems that you may see. Below the slide deck, you'll see a box labeled Q&A. Now that obviously is for your questions and comments for our speaker and our program today, but feel free to put in any technical difficulties or problems that you have also typed into that box. And once again, live people will help you just as soon as they can. We will be posting the full slides and audio in about a week at captodayonline.com, and that will be very useful for some review and sharing with colleagues. I want you to know that you are likely to have some follow-up emails, both from us and potentially from Thermo, so I want you to be well aware of that. Finally, I want you to know that CAP Today does not endorse any services or products that may be named today, and my remarks are, of course, purely personal, not to be taken as policy of CAP Today or, indeed, the College of American Pathologists. And now I want to just read a brief disclosure, and then I'll introduce our speaker. Thermo Fisher Scientific and its affiliates are not endorsing, recommending, or promoting any use or application of Thermo Fisher Scientific products presented by third parties during this seminar. Information and materials presented or provided by third parties are provided as is and without warranty of any kind, including regarding intellectual property rights and reported results. Parties presenting images, text, and material represent they have the rights to do so. Our speaker today was provided an honorarium by Thermo Fisher Scientific for this presentation. And now let me introduce our speaker a little more formally. Dr. Yi Ding is a MD and PhD. She trained at NYU and Cornell in New York City, where she spent many years, and now enjoys her position at Geisinger Medical Center in Pennsylvania, where she is the System and Core Lab Director for Molecular Diagnostics, and she's the Associate Director for the Pathology Residency Program at Geisinger. We're delighted to have her here. She's got a wonderful presentation, and I'll invite Dr. Ding to begin now. Dr. Ding.
Thank you, Bob, for the introduction. Good morning or afternoon, everyone. Depends on where you are right now. I'm glad to meet you virtually and share with you our experience on molecular oncology testing. So let's get started. So on September 28th of 2021, almost 3 years ago, New York Times published an article titled with "A Cancer Without Chemo, Totally Different World." Although we almost never think the cancer therapy has progressed fast enough there are growing numbers of cancer patients, especially those with breast and lung cancers, has been spared the dreaded treatment in favor of other options. And that, like what we called the quiet revolution in cancer treatment. Different from the conventional chemo, which act on all dividing cells with unbearable side effects, target treatment specifically disrupts signaling pathway unique to cancer cells. So although we will be focusing on solid tumor molecular testing today, I would like to give you an example in acute leukemia treatment here. So for acute myeloid leukemia, the traditional chemo is called 7+3. Few therapeutic approaches for malignant disease has remained the same for more than 40 years. One notable exception is the use of 7+3 in AML. Last year, 2023 marked the 50 years anniversary of this treatment regimen. This treatment is 7 days long with nonstop IV infusions of the chemo drug. And one of the most important indications for treatment success is that patients have an empty marrow by day 14. This also means that the patients are pancytopenia and have to be remained inpatient for weeks. The introduction of multiple target treatment in AML are gradually changing this picture. To make it happen, it requires rapid genomic profiling, and this could be a different discussion on another day. So, everyone in healthcare knows that lung cancer is the second most happened malignancy in either man or woman, and it is causing the most death among cancer. Fortunately, non-small cell lung cancer also has the most targeted therapy available by far. There are at least 31 drugs targeting mutations in 11 different genes. Here, the NCCN guideline lists all of them. Before I get into the data, let me first introduce the setting of our current practice. So where is Geisinger? It is an integrated healthcare system located in Pennsylvania. I like this map, and the colored area is our primary catchment, and the main campus is in a small town called Danville. Every time I show this map, I'm reminded James Carville, the political commentator's famous description of Pennsylvania, that is Philadelphia to the east and Pittsburgh to the west, with Alabama in the middle. So we serve the entire central portion of Pennsylvania, which is largely small towns and rural population. So why is it related to molecular testing? If we don't offer this test in-house, the turnaround time of send-out tests for our system would be significantly prolonged due to there is no nearby major airports. We offer in-house comprehensive tumor genomic profiling and research since 2022. This is a summary of the volume in the past 30 months. Approximately like 4,000 cases were sequenced. The average turnaround time is 8.7 days, with 93% of the cases reported by 11 days. Lung cancers consist of approximately 30% of the total volume, followed by colorectal cancer and a comprehensive panel. The comprehensive panel includes more than 500 genes. Something I also want to point out is that there is a heme lymphoma panel in this graph. Besides this, we also offer several heme-based NGS testing, which are not included here. There are also customized NGS assays, but they're in a relatively small volume. Like it or not, the samples of molecular testing are getting smaller and smaller. So it is crucial to any molecular labs to be ready for this trend. Overall, more than half of the sequenced specimens are cytology specimens. And in this graph, which in this red rectangle, it shows an assay which is specifically designed for cytology-based pancreatic cyst or bile duct brushing cases. So here, this assay is 100% cytology. Our thoracic panel, which is for lung cancer, consists of 81% of cytology specimens. And you can also tell across the board, like many different panels consist a lot of cytology specimen too. In this graph, we show that cytology specimen for lung consists of about half of all cytology specimens for all the specimens we received. What does it mean? It means that majority of samples we are handling are tiny samples with little material to work with. This is a critical factor we have to consider during the planning. A common question being asked is that, what is the tumor cellularity cutoff for testing? So although it is important, however, besides the tumor cellularity, the size of the tumor tissue are also important. So before we started the planning of our comprehensive testing panels, we have done a thorough literature search and focused on different test methods and also their successful rate in the cytology-based specimens. Besides that, we have also done analysis of different factors contributing to NGS success, which include different steps of the tissue processing. So I want to point out the block age, because usually you will hear that the older the specimen, the less likely it will be successful. It is true, but not 100%, because if we store the tissue block in a freezer of -20, or -80, it's usually means that block, the DNA extracted from them can last for much longer. But unfortunately, most of the block storage conditions are not really tightly controlled. We have also seen some older block which were stored in a condition that even mold can grow on it. In that kind of case, you can imagine the successful rate of DNA or RNA extraction will be much lower, and that impacts the success of the NGS testing significantly. So we select an amplicon-based NGS assay, which includes 517 genes and sequencing more than 1 million base pairs. At the beginning of our validation, we target as 20 nanogram of DNA input. But retrospectively, here is our summary. Using the non-small cell lung cancer as an example, surgical pathology case consists of about 19% of all the non-small cell lung cancer cases. And 100% of them has more than 20 nanogram of input in DNA. And all of them were successfully sequenced. However, majority of the sample are from cytology specimens, and more than half of them has less than 20 nanogram of input. The successful rate for the cytology-based specimen is 95%. For our NGS-based solid tumor testing, our overall sequencing successful rate is 97.1%. before we started in-house testing, our previous send-out test, the overall QNS rate, which means the quality or quantity not sufficient, is about 13%. And that caused a lot of unsatisfaction in our hem-onc group, because after waiting for weeks, they receive a result of QNS, which means patients need to be respecimened if they want to be retested for a result. With this high successful rate, our satisfaction rate from the hem-onc are significantly increased. By morphology, non-small cell lung cancer can be separated into primarily adenocarcinoma and squamous carcinoma. There are also other types, but the number is very small. So my talk today is focused on the squamous cell carcinoma and the adenocarcinoma. For squamous cell carcinoma, the publication has expected mutation rate in the major three mutation genes. In the major three genes are PIK3CA, FGFR1, and PTEN. Our observed mutations are very similar compared to the published data. In the adenocarcinoma, the two major genes mutated in the advanced stage are the KRAS and the EGFR. Each consists of about 30%. And in KRAS, G12C is targetable, and EGFR is also targetable in the many activating mutation types. Here is our data. So in KRAS, our overall mutation rate is similar, but a little bit higher. In G12C, it's about 4% higher than the published percentage. It's very similar in the other mutation type. Interestingly, in EGFR mutation, when I joined Geisinger in 2018, one of the many questions being asked is that why our EGFR mutation rate is so low. At that time, we observed about 6 to 7% of EGFR mutation rate in our patients. Hem-onc are anxious, and they were questioning if our test is comprehensive enough. At that time, we were using a PCR-based single gene test. With the improvement of the test and now including all mutations we could cover, we confirmed that our EGFR mutation rate is low. Overall, it's about 8.4%, which include both the activation and the drug resistance mutation. And it's also reasonable because in central Pennsylvania, more than 95% of our population are Caucasians. So besides the commonly known EGFR mutations, this test also can detect copy number variants. We have observed that EGFR amplification and then the co-mutation of the amplification together with other activation mutations. This is also important because it has been published that the EGFR amplification can be associated with the TKI resistance. So not only testing the commonly known activation or drug resistance mutations, detection of other mutation types is also important because it can be associated with the overall treatment effect. Next, we move on to the MET, which gave us a lot of nice surprise. In the publication, it's expected the MET amplification is about 2.5%. In our testing, we have observed a much higher mutation rate. If we separate this MET amplification in two categories, over 10 copies, we call it a true amplification, and less than 10, but more than 4 copies, we call it lower level amplification. In both categories, we have observed like a pretty high rate of MET. Overall, it's 10%. It's approximately 4 times comparing to the expected MET mutation rate. There's also a slight increase in the max exon 14 skipping mutation in our patients. It is known that like the MET amplification detection by NGS can be concordance with the FISH assay, which we used as the gold standard. But it depends on like what's the copy number cutoff you call it as the amplification. And also, it's commonly known that the MET amplification detected by NGS is usually underestimate the amplification rate. In a literature search, we have found out this MET amplification can be associated with readout exposure. We have interest to continue this research, but it's going to be hard to really measure the readout exposure rate and the intensity in our patients. So for the ALK, ROS1, and RET fusion, in our local patients, the fusion detection rate in these 3 genes are relatively lower than the published mutation rate. Besides that, for BRAF and ERBB2, which is also called HER2, we have observed a significant higher mutation rate. Currently, we don't know what's the cause of that, but it will be one of our future research interests. Something else to point out is the NF1 gene. Although this is not targetable, their publication has discussed that like NF1 co-mutation with KRAS or EGFR may have some impact on the targetable treatment for EGFR or KRAS. And in our patients, we have observed about 4 times compared to the expected mutation rate. So besides all those single gene mutations, there's something else like we have found interesting about in the non-small cell lung cancer, which is the tumor mutational burden. So in our during our validation, we categorized TMB as low, intermediate, or high. The more than 15 mutations per megabyte, we call it high, and then between 10 to 15, we call it intermediate. In lung squamous cell carcinoma, we have 23% of cases are in the 10 to 15 mutation per megabyte category, and then 13% of them in the TMB high category. The overall percentage is higher than the TMB in adenocarcinoma. For adenocarcinoma, 15% of them are in the TMB high category. The mean TMB for cases which has EGFR ALK, ROS, or MET mutated non-small cell carcinoma is lower. The average, the range is between 3.1 to 6.2. And the mean TMB in the BRAF or KRAS mutated non-small cell carcinoma is a little bit higher than that, which range between 9.7 to 10.3. Very interestingly, for our patients which has high or intermediate TMB in adenocarcinoma cases are not associated with MET, KRAS, EGFR, ALK, ROS, RET, BRAF, and HER2 targetable mutations. Because previously we know that many of these mutations are mutually exclusive, but it's very interesting to see that the high and intermediate tumor mutational burden cases are also not associated with mutations in these single genes. Because of that, we summarized all these mutations, which include the single gene targetable mutations, and together with TMB higher than 10 mutations per megabyte. And overall, in the adenocarcinoma, we have observed about 58% of the patients could be targetable. And in the squamous cell carcinoma, because none of those single gene mutations are currently having FDA or NCCN guideline indicated treatment, TMB high or intermediate could qualify the patients for treatment, and that's about 37%. So here is the summary of what I have presented. So overall, cytology specimen consists of about more than half of overall all the cases we have tested, and this number is particularly high in the thoracic panel, which are about 81%. Test QNS rate has to be controlled in a really low level, which will ensure the overall NGS test successful rate. Also, workflow improvement is very important. Our overall NGS QNS rate is 2.8%. Our test is carefully selected to ensure that the low nucleic acid input can work out. In the central Pennsylvania population, we have a lower EGFR mutational rate and higher MET mutational rate. This is important for our oncology colleagues, so they could be preparing for the appropriate patient treatment. It is also important to know that the whole picture. For the therapeutic targets, about 60% of lung adenocarcinoma and 37% of lung squamous cell carcinoma patients are qualified for target treatment. There are also some future insights which we learned from our own data. But there's still many questions to be answered. So why I named my talk as "It's hard to treat what you cannot see." Because previously there are lots of tests which are single gene based. If we only test that, or even for the EGFR testing that only test those known mutations, but without coverage of the amplification or other copy number variants, we could really miss a lot of those mutation, the network effects of all these mutations. I actually don't know exactly where this chemotherapy and targeted treatment really cross. But at least in our local data, I know like these two lines have crossed. And then more than half of our patients, like in the non-small cell lung carcinoma category, they are eligible for targeted treatment. So I will conclude with this picture, which the river is called Susquehanna River, and then like Danville is really located in this valley area. It's very beautiful and then like very suitable for family raising. I'm happy to take any questions, and thank you for your attention.
Dr. Ding, thank you so much for that presentation. It's extremely interesting. You've got a lot of data that you've shared, and I'm sure it will raise a lot of questions. So anyone who'd like to ask a question or make a comment can type that in the Q&A box below this very beautiful picture of the valley there with the Susquehanna River. Let me begin by going back. Can you find the slide that's been requested, the factors that contribute to NGS success?
Yep.
Okay, there we go. So specifically, just to go over some of this again, with specific attention to the question of the cellularity on the slide, okay?
Let me read the question. So could you please show the slides, and then to be specific, the cellularity slide, and the next slide after that, the cellularity. So basically, like there are many factors contributing for the test successful rate, right? So during the validation, it's very important to include all the possible sample types you will be using in the real life. For example, like for lung cancer testing, like really like 81% of our specimens are cytology. So like testing like cytology, like or using a lot of cytology specimens are very important. And now across the board, which was a surprise, like after we went live, that like more than half of the cases are cytology. So when selecting the test like platform, it is important to make sure that like the test has a really low nucleic acid requirement. Otherwise, lots of the specimens will not be sufficient, right? So in molecular lab testing, although we have a rejection rate, rejection criteria, but usually you don't reject a specimen. We will try very hard to get every request done, and if really like there's nothing detected, then we report as a QNF. So with that kind of rule, we repeatedly like confirm that like even lower than 20 nanogram, like during validation, like you can achieve a really, really high successful rate. So we are enrolling like into a study that like to officially like testing like cross different assays that like the lower DNA input, like where is that limit? And of course, like to prevent the low, the possible false negative cases, right? To ensure that like appropriate like amount of tumor tissues are included, which is also important. I have given like multiple talks within our institute because sometimes, although there is no pathogenic or likely pathogenic like mutation detected, it doesn't mean like there is no tumor, right? Like they are tier 3, which is the NOS, and also like even with like a true negative we're reporting, like there are lots of background, like those mutations, like usually we filtered out, but like those can tell us a lot of information. So when we see a case which is quote unquote truly negative in the unfiltered data, we will reach out to our pathologist and tell them like, probably like the block could be run out of tumor tissues, like can you resend us another different block? So they are very complicated, like quality control procedures, like in the NGS testing. And to ensure all these factors being considered during validation is important.
Thank you. Thank you very much. Let me just ask you, Dr. Ding, I know you've covered enormous area within the Geisinger system. Could you comment about the distribution of where the samples come from? In other words, what percentage are taken in Danville itself at the flagship, and what percentage come from other sites within the Geisinger system? I hope I'm clear on that.
Yes, it's clear. So our healthcare system has gone through a consolidation process, and during that process, like we have centralized all histology work in Danville, and thus like we also have centralized molecular testing at Danville. So basically, all the specimens like we received from here are from like all over of our healthcare system. We also unified our medical records system, like the electronic medical record system. So that helps us a lot in the data management too.
Thank you. Tell me, while we're on this, what your rejection criteria are for samples. There's a questioner asking about you see the rejection criteria for sample concentration under 20 nanograms. Are there some additional criteria that are used to reject a sample?
I might not be clear enough when I talk about this. The 20 nanogram was really suggested by the assay when we choose it, but like during validation, we have lowered that criteria significantly because we know cytology will be an important like sample source. So we have tested like to much lower sample input like in that category. So our lowest like DNA input now is 1.5 nanogram.
Okay. Thank you very much. Let me just ask you, you list as a 2.8% quality not sufficient. Is there an ideal goal that you're striving for? I realize you would not want to have any samples that were not sufficient, but are you looking to drive down the 2.8%?
I can share with you because previously our send out reference lab, their QNS rate was 13%, right? Like, and that drives us to bring the test in-house. And and then like after we brought it in-house a couple years, the lab came back to us again and said like, oh, we really improved our QNS rate, and can you reconsider to send it to us? And I asked, I said like, oh, what's your current QNS rate? And I was told that's 7%. So and this is a really big reference lab, and after I told them our current QNS rate is 2.9, no, 2.1, like really less than 3%. And they were like, oh, instead of asking us to send them, like they asked for collaboration for research. So,
okay.
so I don't know, like, of course the optimal is 0% QS rate, but like, I don't know if any lab in real life can achieve that.
Right.
Yes.
I can certainly understand that. So that actually is by this example alone, an extremely positive rate at 2.8 when the reference lab is much higher.
Yes.
Understood. Right. Now, we have several participants, and I share that same curiosity. Why, do you have any insights or hypothesis about why the EGFR mutations are lower in your experience within the Geisinger system? Is it a question around the panel coverage, do you think? Or could it just be a matter of the population that's unique to your area? What are your thoughts about this?
We used to think the test was not good enough. Okay, we used to use a test that has limited exon coverage for EGFR, and at that time, like even this paper was published in 2017, we were still not sure, right? Because we know our tests are quite limited. And then we improved the test to a different product, but like without a really significant increase of EGFR. At that point, we know like probably it's because of the population composition, and that result was confirmed after we implement the NGS testing. So using different tests and over multiple years, like really confirmed that like the most likely contributing factor for the low EGFR mutational rate is because of the population composition.
Okay.
Yeah.
That's very interesting to me. There's one quick question I want to make sure we get a chance to ask you, Dr. Ding. Do you have any experience in the central nervous system solid tumors?
Yes. Actually, like the new WHO guideline for central nervous system, like very molecular heavy. So the test, like we offer, covers lots of CNS tumors, and we also ensure that like a faster turnaround time because a lot of them like depends on molecular testing for tumor classification. I also want to mention that like for our cytology-based pancreatic cyst and bile duct brushing case, like we have prioritized like those testing too, because we have formed a new model like of reporting these assays, so cytologists can really integrate our result into their final report instead of like issue separate reports and then like add addendum. This also requires a closely collaboration with the gastroenterology group to help like them to management the patients.
Okay, very good. We have, of course, some sample questions here. First, could you address the question of restrictions that are due to the need for decalcification of tissues?
That's a really, really good question. So the regular decal specimen, we don't accept those because of destructive DNA integrity.
Yes.
So like we have tried different like decal, like EDTA decal, but like even the EDTA decalcification solutions, there are many types of them. Like currently, the EDTA decal we're using are not suitable. because we have done a comparison of the DNA quality. So our current solution is that, like, for those case, we prepare a block without decal. So there is a decaled block and there also a non-decaled block for the molecular testing purpose.
Okay. Thank you very much.
It's not optimal, but like that's our current solution.
I can understand. Let me ask you one more question around the cytology samples. What is the majority of those samples? How do they come? Are you extracting material from the FFPE cell block that's prepared?
Yes. So for cytology, so the only specimen like in today's like reported data, which is fresh, which is that like the cytology-based pancreatic cyst fluid and bile duct pressure. Everything else like are from FFP, like the cell block, right? So they are the same sample processing comparing to other like surgical specimens. So we are not using the cell smears. It's the cell block.
Very good. Very good. Thank you. We have a question, of course, as you might expect. What is your turnaround time for the NGS test?
I have shown that. So our average turnaround time is 2.7 days. So we gave HEMONC a monthly report of our turnaround time and detailed with every single different panel.
Okay. That's extremely useful. Next, we have a question, as one can imagine one would. Let me read it to you. Was it difficult to get buy-in from oncologists for this centralized testing workflow? Other than decreased QNS, was there anything else that resonated with those oncologists, like turnaround time, communication with pathologists, or an integration with molecular tumor boards? Could you just talk about what I might call the sociology now of working with your oncologists within the Geisinger system?
This is a great question, right? So in Geisinger, and this is not only like offering a good test is good enough kind of question. So in our healthcare system, like all the send out tests are sent through our referred lab in pathology. So of course, like a better turnaround time, a lower QNS rate are important. Another critical factor is the billing. So I remember one of the first questions, like after we discussed that, like we're going to offer this test from oncology was, is the patient going to receive a bill? Okay, like of course there is that like non-surprising like bill law, but how you help. So in our healthcare system, like we have our own like insurance. It's called Geisinger Health Plan. So we work closely together, and they are really forward thinking. So in our past 4 years, we have like a handful, less than like 10 fingers, like cases we have received that like patient may have a question, but our billing team can always work together to get it solved. So that's really, really helpful because nobody, like currently there are quite some reference lab, they offer those like patients out pocket $200 kind of scenario. And at the beginning, like our oncologist was asking, can you match that offer? Which we could not, right? We are non-for-profit lab. We cannot match that like top maximum like $200 like payment. But like with our unique setting of Geisinger Health Plan, and then like a really, really helpful billing team, I feel like that gives our oncology team like a really high confidence, right, to work with us. So to ensure us that like instead of like sending more case out, keeping the specimen in-house are really beneficial. So they have seen like a much shorter turnaround time because as I mentioned even shipping the specimen out of the area could be a challenge. And
Yeah.
reference lab always count like we are similar, right? Like we count the turnaround time from the moment that you receive the specimen, not you receive the order. But like if it's in-house test, the time of receiving the order and the time of receiving the specimen is really short because histology and molecular lab are in the same building. But like if you send the case out, that could be like more than a week sometimes. So it's really like the trust has to be earned. It's this high quality of test has given like lots of confidence from our oncology. And of course that like we're just tag or text away, so they can always text us and we let them know that like if they have any patients like have a sooner appointment, just let us know. We will prioritize the case and giving them like the result. So it has been working really, really well in our system.
Good. I've got a couple of questions here. First, a scientific one. How many samples do you require for validating a particular marker now or mutation?
The magic number from a previous, like a really well-known paper was 59, N equals 59. But in real life, like for a test, like we are doing our own like validation, we follow the New York State like requirement. So almost every of our tests has more than 100 case like tested, like used in the validation stage.
Okay. And then another question about the number of samples, but at this point, really, we're talking about economy and efficiency. What do you believe is the minimum number of samples in order for you to perform a run of NGS efficiently?
So to answer that question, I have to go back a little bit because to discuss like what test to bring in-house, right? You have to have a procedure or like to evaluate what test should be brought in-house, right? And the volume of the test is an important factor. If you cannot even support, the volume is so low, cannot support like everything you need, then probably you have to wait a little bit and see. We have used our previous and now volume like to start, and although we know the volume will increase significantly, like it's still kind of grow like much faster than we expected. So currently we don't have a problem like to run enough runs, but like for each chip we're using, there are 6 specimens plus controls, right? So I will call that as a minimum number. If you have lower than that number, then probably like, not probably, for sure, the cost of the test will increase. But 6 is our sweet number, like to really maintain the like our validated like quality, and then like and then cost wise. So that's our sweet number, 6 number in each.
Okay.
But also depends on the size of the chip.
Of course, of course. No, very good answer. I was wondering when we would get around to this, but let me ask you, with your responsibilities for molecular testing and molecular laboratory, can you just give me a brief overview of your thoughts and reaction to the potential FDA regulation of laboratory-developed tests?
Yes. So I think every molecular lab has to prepare for that because our lab, more than 90% of our tests are not FDA approved, but most of them were implemented like before May 7th of 2024. We also follow the New York State validation criteria. Hopefully that would be a really positive factor for us. And going forward, we recently launched another NGS-based test. We follow the same validation criteria, and we are anxiously waiting for CAP or CLSI or the current policymakers what's the direction and how to guide all these labs, what's the next steps, right? But quality-wise, we just want to make sure that we are ready for any kind of requirement.
Very good. Very good. Thank you very much. Let me just ask another couple of questions here. We're getting close to the top of the hour. As you rightly point out, non-small cell lung cancer occupies an enormous percentage of the tests that interest you for the variety of mutations and also agents that are used for those individual mutations. So the following question is this, and I'll read it to you. Can a targeted 50-gene NGS panel be acceptable for molecular biomarker testing for non-small cell lung cancer? Or would whole genome sequencing be a better option for patient management? What's your opinion about that?
I would say every test is limited. There is no perfect test, right? For example, a 50-gene NGS panel probably covers all the 11 genes like we talked about, but a 50-gene NGS panel will not be suitable for giving an accurate TMB number, tumor mutational burden, right? It depends on what's the weight of each of the biomarkers in the management, right? And also to find a suitable test for your patient, for your community and patient population, right? Of course, offering a really large panel, several hundred genes that requires a more input, in data storage, data processing, annotation, quality control, all of that. But it does offer a lot more information. But if that's not something could be provided, a limited panel could be considered, right? But this decision should not be just a molecular lab decision. It always should be done among laboratory and then oncology, to discuss what's their needs, because validate of any NGS panel is not a small work.
Of course.
You don't want to do a test which is not sustainable or not fit in several years, you know what I mean? Nobody can plan really what's the best test in 5 years, but we should all prepare something can be upgraded.
Of course, but yes, good answer, very good answer. I'll close with this question for you, and just briefly, could you describe your bioinformatics pipeline? For example, which staff do the QC checks, and who reviews the variant calls? Is that you or colleagues? And then who does the report annotations?
That's also a great question. So at the beginning, so the test development and validation is a teamwork, and then we have PhD level lab associate directors in charge of those. And at the beginning, the PhD scientists will do all of that, but then we transfer these duties to our lab staff. So as you can imagine that in central Pennsylvania, recruiting can be difficult, right? So lots of our staff are local people, and they are extremely good and trainable. So as you mentioned, I was trained in New York City, and I was spoiled in some way of there are many more qualified person in New York City we can hire, but in central Pennsylvania, I have realized and changed my mind that if people are engaged and want to learn, a lot of stuff does not need that kind of degree to do the job. So our laboratory staff, which are mostly medical laboratory scientists and technologists, they can do the QC. Variant calls, they can also do the variant call, but we have PhD scientists review them before going to molecular pathologists. So there's always multiple layers of the review of data. I have to say, it is a big team.
It is a big team, and Geisinger is renowned for its wonderful laboratories and its wonderful laboratory team. I'm fortunate to know many of them, and certainly we all appreciate it throughout the country. What a wonderful operation they have at Geisinger. And particularly for your wonderful presentation today, Dr. Ding. This has just been really wonderful, and we want to thank you. So let me now take the time to wrap things up. Obviously, we want to thank Yi Ding. Dr. Ding has given us an enormously interesting lecture full of rich data and comment. You can review that in about a week or so at captodayonline.com. I'm sure you'll want to be going back through that. So we want to thank Dr. Ding. We want to thank as well Thermo Fisher Scientific. Programs like this are really not possible without their help and support and their educational grants, so we acknowledge them. And finally, I do wish to thank all of you. You're taking time out of very busy laboratories, often very short-staffed, to spend some time with us, and we're very grateful for that. And once again, to wrap up, thanks to Dr. Ding, thanks to Thermo Fisher Scientific, and thanks to all of you for your attendance today. And with that, I'll bring today's webinar to a close.